everyone. I would like to welcome you all today to the International Journal of Clinical Research, particularly to our Pioneer of Webinars series that we have here. And I just want to say that we are honored to have with us today Dr. Razelle Kurzrock, who's a leader and inspiration in the field of oncology. And we're excited to hear her presentation, Precision Oncology, Genomics, Immunotherapy, and Beyond. My name is Jake Muldoon, and I'm the host for today. And I've had the absolute honor to be able to be here part with the journal IJCR. And we really, although I'm a chemist, I also consider myself an optimist. And we here at IJCR are optimistic about the future of medicine and being able to really engage students in research and publication. And I would like to introduce you today to two people here. I have Ms. Fawaz, who is a current medical student who was involved in the International Journal of Clinical Research, and Dr. Jan Leifman, who is the director of the Pioneers in Medicine, a branch of this journal. Now, Ms. Fawaz, who will be introducing the journal today, has a real passion for being able to engage in research and to be able to reach across community lines for us to be able to make that connection that's always needed in the medical field. As the term international would imply, we have a team of fantastic people, and I'm absolutely honored today to be able to introduce to you Ms. Fawaz, who is introducing you to the International Journal of Clinical Research. Ms. Fawaz, the floor is yours.
Thank you, Dr. T. So, hello everyone. My name is Ala Fawaz. I'm a third-year medical student at the Lebanese University in Lebanon. I'm a member of the Pioneers in Medicine Student Committee, and I'm extremely honored to be presenting the International Journal of Clinical Research today. To start with, by defining IJCR. IJCR is registered as a non-profit organization in Delaware, USA, where it has 0 article processing charges. However, this has absolutely no effect on our high-quality, open-access, double-blinded, and peer-reviewed articles and interactive clinical content for the global community at large. Heading to the aims of the journal, it aims to establish equity in the publishing field by waiving publication fees, making sure that no authors are financially disadvantaged. To guarantee high-quality publications by employing rigorous editorial, peer, and statistical review process to evaluate manuscripts. To encourage and promote scientific research by involving young researchers and medical students like myself, teaching and guiding them through the process of publishing, and to improve patient outcomes by optimizing information delivery, especially from developing countries. Within its scope, various types of research papers are published, including case reports, case series, narrative reviews, and original research. Due to its system and quality of articles, IJCR has obtained indexation from ISSN, DOI, Crossref, Google Scholar, PubLaunch, and DOAJ, and it's through the process of obtaining PubMed and Scopus indexations. Despite IJCR being so young, starting in May 2020, where our reach has started from 5 countries and 9 cities, it has achieved an exponential growth, and now it reached 131 countries and 1,607 cities, and this is the data presented by Google Scholar Analytics. We are more than proud to say that we started the board of advisors, and one of them is Professor Baricat, who is the Dean of the Undergraduate Studies at the University of Sao Paulo in Brazil, who also happens to be the mentor of Dr. Gregory Nicholas, who is the managing editor of the journal. And here I would like to mention that we're looking for esteemed faculties to join us as board of advisors and be part of this growing family. The editorial board consists of multiple editors from different fields of different specialties. They focus not only on obtaining great quality publication, but also on guiding our authors throughout the publication journey. We have esteemed editors from various countries who highly contribute to the maintained quality of the journal. As I've already mentioned, in IJCR, diverse kinds of research are published. For instance, as you can see, these are a narrative review, an original research example, and a case report that have been already published. We have basically 4 divisions at IJCR: the webinar series, the podcast, the course, and the Medical Student Advisory Board, which is also known as the MSAB, each of which will be discussed in a second. starting with the webinar series. Its main focus is to inspire young minds by showing them the accomplishment and research of great experienced researchers and how they impacted the world at large. This series has been prospering thanks to our director, Dr. Jan Liefman, along with the assistant directors, Dr. Keval Dakar and Ms. Hiba Sati. And I'm very proud to be one of the members of the Students' Committee along with my colleagues. Our first webinar was The Road to a Chemo-Free World with Dr. Bruce Chesson. Then we had Dr. Alex Kensis presenting Why Do Young People Get Cancer? After that, we were honored to have Dr. Robert Peter Gale, an expert in leukemia and bone marrow disorders. Heading to the fourth webinar with Dr. William O on precision medicine. Most recently in December, we've had Dr. Patrick Hu as a keynote speaker on using the immune system to fight cancer. And now we're truly honored to have our sixth webinar with the world-renowned physician scientist and leader in precision medicine, Dr. Razelle Kurzrock. We're looking forward to it with ultimate excitement. We have also our podcast, Medicine Beyond Science, by Dr. Jake Muldoon, an optimist, ordained minister, and PhD chemist who has a passion for inspiring stories of others. He has 8 podcasts where he interviews medical personnel, patients, researchers, and special guests to highlight their unique stories, personal experience, and contributions to medicine. And we already have 5 episodes on all podcast channels, so tune in and make sure to listen to the great stories behind each person and to check them out if you haven't. Our last and one of the biggest divisions is the Medical Student Advisory Board, or the MSAB, which is directed by Dr. Nancy Emanuel, along with Dr. Ricardo Vayela and others. This team is putting great effort and contributions to make this journal a global success. We have more than 117 medical students and fresh graduates from 30 countries. As you may notice, students in this chapter come from very diverse backgrounds. The MSAB division is divided into the following 10 chapters, which will be explained briefly. First, we have the Journal Club chapter directed by Dr. Ricardo Vayela. The team provides a Journal Club meeting every 2 weeks, which are exclusive to the members of the MSAB. This chapter teaches students how to read and critically analyze scientific information while giving them the opportunity to develop their presentation skills. Secondly, we have the Research Opportunities chapter, which has given the opportunity to more than 100 students to participate in a research opportunity. We currently have 14 active groups working on writing a scientific article guided by mentors provided by IJCR. Moreover, the Digital Health chapter is responsible for teaching and spreading awareness about the digital health, an essential and growing field that each physician must know about. In addition to the Pioneers in Medicine Student Committee, which help in organizing the webinars that we have already discussed. Heading to the Growth and Development chapter, which offers every month 1 session of community building activities and a workshop on growth and development. We also have the Social Media chapter, which is responsible for the image of the journal on social media. It teaches students how to manage a professional account and build teamwork and leadership skills. Hands-on writing skills, in collaboration with IJCR Intersect, provides students with a hand-on writing experience through which students develop their writing skills directly with a mentor. The International Students Outreach chapter gets external collaborators and educational services that IJCR offers for free for associations internationally. Furthermore, the Juniors Mentor Program is a research course developed especially for the members of the MSAB to guide them from beginners to the advanced level. Last but not least, the USMLE Study Group, which is a newly launched chapter, aims to guide, assist, teach, and motivate students who will be taking the USMLE exam to apply for the match in the US. As you can see, the MSAB has all these amazing opportunities and much more. If you're interested in joining us, follow us on social media and stay tuned. The applications will open very soon. Thank you so much for your attention. I'll leave you now with Dr. J.
Thank you so much, Ms. Fawas. And now I would like to introduce Dr. Jan Leifman, the director of the Pioneers of Medicine in IJCR. Dr. Leifman.
Thank you so much. At IJCR, we believe in the free and equitable distribution of knowledge. We also strongly believe that the youth The youth is our future and is directly intertwined with research innovation. Thus, we launched Pioneers in Medicine, an initiative that is almost 1 year old, where we bring to you medicine's most prominent luminaries, discussing their research discoveries and passions, which we hope will inspire you. However, success cannot be achieved without a great team, and I'm very fortunate to have a passionate, dedicated, and hardworking team to make these events a reality. Today we are excited to host one of oncology's and precision medicine's premier global leaders. This individual is a trendsetter, and with her magical touch has refined clinical care. Allow me to highlight just a few of her many and astounding accomplishments. She founded, developed, and chaired one of the largest phase 1 clinical trial departments globally at MD Anderson. She's recognized as one of the most cited scientists internationally and amongst the top 25 global leaders in precision medicine. She transformed the oncology divisions in both MD Anderson and UCSD. While at UCSD, she also served as the chief of hematology oncology. Now, I bring this up for one main reason: representation. According to Chowdhury et al. From JAMA Oncology, published in March 2020, females only comprise 21.7%, or 30 out of 138 of chair positions in medical oncology. The numbers are even less for radiation oncology and surgical oncology. The authors concluded that gender disparities exist in academia and is further magnified at the chair level. So it is only apropos that we feature such a luminary as Dr. Kurzrock as our first female speaker for our Pioneers Lecture Series, especially during the month of March, in line with International Women's Day, a global celebration of female success and excellence. Now, Dr. Kurzrock is a legend in every shape of the word, as a physician, as a researcher, as a visionary, as a mentor, and most importantly, as a person. We hope that after today's event, you too can be inspired. And now for the formal introduction, I would like to introduce Associate Director of Pioneers in Medicine, Heba Sati.
Thank you, Dr. Yan. I am really honored to be introducing such an exceptional and inspirational speaker. Joining us today is a world-renowned physician, scientist, and global leader in precision medicine, Dr. Razelle Kurzrock. She is recognized for founding, developing, and chairing one of the largest and best-known phase 1 clinical trial programs in the United States while at MD Anderson Cancer Center. Additionally, she has been the principal investigator at the National Cancer Institute U01 phase 1 studies of targeted anti-cancer agents, as well as one of the pioneer clinical trialists of the Winter Precision Medicine. This trial focused for the first time on transcriptomics in addition to genomics, and it was the signature study for the WIN International Consortium. Dr. Kurzrock is currently the Associate Director of Clinical Research, as well as the Associate Director of Genomic Science and Precision Medicine Center in the Medical College of Wisconsin Cancer Center. She is also the Chief Medical Officer and Executive Committee member in Worldwide Innovative Network for Personalized Cancer Therapy. Remarkably, Dr. Kurzrock has a special interest in rare cancers. During her time at the University of California, San Diego Health, she led the Center for Personalized Cancer Therapy, as well as the Experimental Therapeutic Program. She also founded a rare tumor clinic focused on precision medicine. The signature study of the center was the iPredict, which was in 2019, that gave for the first time individualized matched combination therapies to patients with lethal malignancies, resulting in improved outcomes. Despite her numerous scholarly contributions, what Dr. Kurzrock is most passionate about is improving care for patients with cancer. Thus, patients are always at the heart of her work. Although her achievements are too many to count, I will briefly highlight some of them. She is the recipient of the Emil J. Freilich Award for Outstanding Clinical Research, PPW Texas Past State President's Award, and the Otis W. and Pearl L. Walters Faculty Achievement Award for Clinical Research, amongst many others. Dr. Kurzrock has authored over 800 peer-reviewed publications and has an H index of 130 in such journals such as NEJM, JCO, Lancet Oncology, Lancet Hematology, and Cancer Discovery. She has been recognized as one of the most cited scientists worldwide and amongst the 25 most important voices in precision medicine across the globe. Not only that, but she also has a uniquely strong record of competitive funding with more than $100 million in lifetime funding. It is a great privilege to have you as our keynote speaker today, Dr. Kurzrock. We are very excited to your presentation.
Thank you.
Thank you, Ms. Sati. And with that, the moment we've all been waiting for, Dr. Razelle Kurzrock, we're excited to hear that not only is this such going to be a fantastic talk, but not only that, we have just a great group of attendees that are here. These attendees are comprised of prominent faculty, oncology trainees, and staff here at IJCR. And I want to say that everyone, please feel free to ask questions in the comment section. And in order to be respectful of everyone's time, we will be selecting questions for Dr. Kurzrock to address at the end of this session. Dr. Kurzrock, so excited. Thank you so much for being a part of this. The floor is yours.
Thank you so much. And if you want to put the slides on the screen, that would be great. And thank you for the lovely introduction and also for the work that you're doing with IJCR. It's really very, very impressive and important. Wonderful. So I'm going to talk about genomics, immunotherapy, and beyond, and how precision oncology affects all of them. Next slide, please. These are my disclosures. Next slide. And my thinking about precision oncology has been influenced by two experiences, mainly. First, the MD Anderson Cancer Center, building the early phase program where patients came to us that had failed all therapy. And this was over a decade ago, but we began to get a glimpse of how genomics could improve outcomes. And more recently at the directing the Center for Personalized Cancer Therapy at Moore's Cancer Center, as the sophistication in genomics grew. Next slide. Next slide. So the take-home points, which I'll start with, the message that I want to get to you. It's all about getting the right drug to the right patient at the right time. And the basic principles is that patients with metastatic tumors have unique and complicated genomic portfolios. And that means that the tumors need to be matched to the right therapy, and that it is unlikely that single agents will be enough to impact all the things that are wrong with these tumors. Next slide. So what I'm going to start with is just some patient cases, and with one of the hardest cancers, pancreatic cancer. The 2-year survival for advanced pancreatic cancer is still about 7%. And almost all patients are diagnosed in an advanced state. Next, please. Next slide, please.
Okay, change to the next slide. It doesn't show.
Then keep going to the slide afterwards. Oh. In spite of that, only about 10% of pancreatic cancer trials are biomarker driven. And what we want to show is you can't win the race if you don't enter it. So there's this rumor that matched targeted therapy and immunotherapy don't work for pancreatic cancer. But what we are going to suggest is that even for pancreatic cancer, which is so difficult, the real problem is that not enough clinical trials, 90% of clinical trials have not actually attempted to match patients with the right drugs. Next slide, please. So we recently published a paper with Dr. Boda, a young faculty at UCSD, and looking at pancreatic cancer and matched immunotherapy. And this is the paper published in JCI Insights. using chromatin remodeling genes as a biomarker of immunotherapy efficacy in pancreatic cancer. Next, please. If it doesn't go, just keep going. Oh, could you go back one, please? Great. What we were able to show is patients who have chromatin remodeling gene abnormalities, they actually respond very well to immunotherapy, even in pancreatic cancer. So that rumor that pancreatic cancer does not respond to immunotherapy is really not correct. These are rare abnormalities, but in the 9 patients that had one of these genomic abnormalities, and they're in genes like ARID1A, SMARC, and so forth. 8 of 9 achieved an objective response with immune checkpoint blockade, including complete remissions, and the 2 longest responders are ongoing at about 3 years. So the bottom line is that there are subsets of pancreatic cancer that are genomically driven, even the most difficult disease, that can respond to immunotherapy. And it's a matter of utilizing precision medicine to find those patients. Next slide. And the same is true for matched gene targeted therapy. The conventional wisdom is that pancreatic cancer doesn't respond to immunotherapy. It doesn't respond to matched gene targeted therapy. As I mentioned previously, one of the problems with that conventional wisdom is that 90% of the trials haven't tried to match the patients. So this is an example of a patient who has several abnormalities that are not atypical for pancreatic cancer, CDKN2AB loss, KRAS, and a SMOD4, and a TP53. Next slide. And the patient was matched with trametinib, with a CDK4/6 inhibitor, and with bevacizumab. Next slide, please. Next slide, please. Next slide. And when we do this matching, where we target more than one alteration, what we find is that patients respond even when they do not respond to targeting a single alteration. So this is a publication that we put out in Clinical Cancer Research last year, and we showed that 5 of 9 patients responded to co-targeting cell cycle and MAPK alterations with CDK4/6 inhibitors and MEK inhibitors. We know that individually these drugs don't work, but when we use them together in patients that have the cognate alterations, then we see responses. And so what I think we're beginning to understand is even in difficult diseases like pancreatic cancer, one of the essential things is that we cannot target single alterations. We need to co-target the different drivers that are present in the tumor. Next slide, please. So all of this has led to an evolution in clinical trial design. And what has been happening in clinical trial design is almost unimaginable from 10 or 15 years ago. And I think this is happening more and more rapidly, but we really needed this evolution or revolution because patients with metastatic cancer were not doing well, and it acknowledges what we are seeing in the next generation sequencing. So what we've begun to understand is lung cancer was usually thought of as one disease. Now we know it's many diseases. Next slide, please. So some of these changes have driven, as we begin to understand that lung cancer is, as an example, no, please, yeah. Next slide. That lung cancer is many diseases. And then furthermore, we have begun to understand that the same genetic defect can occur in many different diseases, and that each individual has their own genomic portfolio. This has led to FDA approvals, which we would think were unimaginable a decade ago. So the first of these was pembrolizumab, immune checkpoint blockade, which is approved for solid tumors based on microsatellite instability and mismatch repair gene defects. So what is special about this? This changed the entire model for thinking about cancer. First is a tissue agnostic approval. It's not for lung cancer or colon cancer, it's across the board. And secondly, it's an approval based on a genomic marker. Now, that was the first of the approvals, but it's definitely not the last. Since that, we've had larotrectinib for NTRK fusion, adult and pediatric solid tumors, entrectinib for, again, NTRK fusions. More recently, pembrolizumab for high TMB tumors. Again, tissue agnostic approvals. Next slide, please. Next slide. And more recently, belzutifan, which is for HIF, hypoxia-inducible factor inhibitor for adults with VHL disease, and dostarlimab, which is another anti-PD-1, again, for mismatch repair gene defects. And then what I think is a really interesting approval. Next slide, please. Is this approval? Razelle. So obviously very similar to my name. Can't figure out how we got that. But I'm on Twitter, and I have to say, everybody contacted me and said, where does this name come from? At any rate, it had nothing to do with me. It's just a coincidence. So next slide, please. So the next thing that I'm going to address is the marriage between genomics and immunotherapy. So the pillars of precision or personalized medicine are genomics and immunotherapy. And many people think of them separately, but we think of them as a couple, and they're married to each other. And what do I mean by that? This is an example. The way one can predict response to immunotherapy is based on genomic aberrations. So an example, this is from an early publication from 2017, and then follow-up review in Cancer Cell in 2020 that we published. And of course, now there's the approval. We found that there's a direct correlation with the mutational burden and the response rate to immune checkpoint blockades. So 4% response rate for low mutational burden, for very high mutational burden, up to 67% response rate. So why is there this marriage? The way immune therapy or checkpoint blockade inhibitor work. They work because they reawaken the immune system. But once the immune system is reawakened, it has to recognize the tumor. And tumors that have very few mutations are very hard for the immune system to recognize. On the other hand, tumors that have a lot of mutations are much more easily recognized by the immune system. And so these patients that have a lot of mutations that we really felt bad about, we thought that there would be no way to ever treat them. With immunotherapy, those patients are actually the best patients, and they're the best responders to immunotherapy. So some of our experience has been gained from our molecular tumor board, where we looked at over 21,000 patients with clinical grade next generation sequencing. Next slide. And I'll just show you a couple of examples of some of the things that we learned. So this is a patient with metastatic basal cell carcinoma. He came to see me in October 2015. He was a 55-year-old man. He failed multiple treatments. He had liver, bone, and brain metastases, and he had 6 different therapies, including the FDA-approved therapies of vismodegib and sunitinib, which target the hedgehog pathway, but he didn't respond to any of them. Next slide. So he's pretty close to hospice, but we did sequencing on him. And if you look at the sequencing, I think you can see why he didn't respond to the FDA-approved targeted therapies. He has a patch 1 alteration, so he has the right alteration, but he has another 20 alterations. So how can he respond to one targeted agent when there are so many things that are wrong with the tumor? But this was back in October 2015. We found he had a high tumor mutational burden, and he also had PD-L1 amplification. Next slide, please. So this was through next generation sequencing. Next slide. And so we elected to treat him. Next slide. With an immunotherapy with checkpoint blockade. Ooh, we missed the slide. Can we go back one? Yeah, back one. Okay, well, I'll tell you, we elected to treat, there it is. We elected to treat him with checkpoint blockade. And he went from being hospice bound actually to having a complete remission. His response is now ongoing at 6.5 years in complete remission. As an oncologist, always hesitant to use the word cures, but I think the patient may be cured of their disease. So I think this illustrates, this is not just one patient, but I think on the whole, it illustrates the power of using genomics to pick the right patients for immunotherapy. Next slide. So the other, yes, wonderful. The other point that I want to make is that precision medicine can tell you not only who to treat, but who not to treat. And that's what the previous slide about it's not all good with, as an example, immunotherapy. Immunotherapy's checkpoint immune checkpoint inhibitors are some of the best drugs ever discovered because they, could you progress the next slide, please? Because they result in a subset of patients that has responses that I showed you in the prior patient. And these are some of the most dramatic responses that I've seen in my lifetime as an oncologist. But on the other hand, there's a small subset of patients that also has a problem with immune checkpoint inhibitors. And this is an example of a 44-year-old woman with triple negative breast cancer. And on the left-hand side, you can see her scan. And it's about 2 months before she started immunotherapy. And then in the middle is her scan right before she started immunotherapy. And there's a little bit of growth, but not a lot. But then within 2 months after immunotherapy on the right-hand side, you can see that there's tremendous growth of the tumor. And we noted this, and now many other groups have noted this, that there's a subset of patients that have what we call hyperprogression. And that is, they appear to have an accelerated progression on immunotherapy. It's like pouring gasoline on a fire. And these patients do very poorly. And so we don't understand the mechanism, but what we did try to figure out is, could we have factors that are predictive of doing poorly with immunotherapy? Next slide, please. So you can see that this patient has an MDM2 amplification. And we analyzed our data, and we found two genomic alterations that can predict hyperprogression: MDM2 amplification and EGFR alterations. Patients with MDM2 amplification are at very high risk in our experience and from our database of having accelerated progression on immunotherapy. Patients with EGFR alterations are mainly just plain old resistant, but there's a subset of patients that have hyperprogression with immunotherapy. And what I want to clarify is that, first of all, we don't understand the mechanism. We understand that there's a correlation with these genomic aberrations, but we do not understand what the underlying mechanism is. We are beginning to study that and to try and elucidate that. The other point that I want to make is that not all hyperprogressors have MDM2 amplification or EGFR, and not all patients that have EGFR or MDM2 abnormalities will hyperprogress. However, if one has a patient with an EGFR alteration or an MDM2 amplification, one has to be very cognizant of the fact that they are at risk for accelerated progression with immunotherapy. So here is an very important point. Next generation sequencing can help define not only who to treat, but who not to treat. And that is probably as important as defining who to treat. Next slide, please. So I'm going to give you one other example for our clinic, which shows how we can exploit new technologies for the benefit of patients. This is a 49-year-old woman that came to see me in January 2016 at the University of California, San Diego. She came from Saudi Arabia. She came to our rare tumor clinic, and she had a high-grade neuroendocrine cervical cancer, which is a very rare cancer. She had been treated in Saudi Arabia with surgery, chemotherapy with cisplatin and etoposide, and radiation therapy. And she was very ill. She had a huge abdominal tumor. I mean, she looked like she was 7 months pregnant, but it was all cancer. She had an impending bowel obstruction, partial ureteral obstruction, so very close to kidney failure. And we consulted our urologist, who said, too late for a stent. This patient needs to go to hospice. And probably if the patient was from San Diego, we would have sent her to hospice. We felt a commitment to try and do something for her because she had come all the way from Saudi Arabia, but we had a big problem. We didn't have time to get a biopsy and do next generation sequencing because she really had probably a week or two left to live. Next slide, please. These are the options, what to do next for this patient. We decided to do comprehensive genomic profiling. And because we didn't have time for a tissue biopsy, we did a liquid biopsy, which is looking at a simple blood sample. And so we've had experience now with almost 6,000 patients. You can do a liquid biopsy on any liquid. Some is done on urine or ascites or cerebrospinal fluid, but the vast majority is on blood. And this is, again, an almost unimaginable type of technology where we can take a simple tube of blood and look at shed DNA from the tumor. And this is what we found. So usually when you're looking at the blood sample and you look at genomics, there's about 3 or 4 alterations. And this patient had more than 20 alterations. So this is back in January 2016. And what we thought was maybe she has a high mutational burden. Next slide, please. And so what we did is we gave her nivolumab. And you can see on the left her scans before, and then on the right her scans afterwards. She did go into complete remission. We treated her, as I mentioned, in January 2016. She went back to Saudi Arabia after about 1.5 years. And I know she had an ongoing remission at 3.5 years. And I don't know what's happened since. But this again illustrates the ability to use new technologies to actually impact patients in the clinic. While we were treating her, we did get a tissue biopsy. And the tissue biopsy confirmed what we suspected from the blood. And that was that she had a mismatch repair gene defect. She had multiple alterations. Usually tissue NGS shows 3 or 4 alterations. She had a very high mutational burden of 53 mutations per megabase. And and she was microsatellite unstable. Next slide, please. So I think I will wrap up with this being a really important point to the next slide. So the importance here is that we can use genomic sequencing to match patients with difficult diseases such as pancreatic cancer to the right drugs. And we can also use new technologies as they arrive, cutting edge technologies, such as liquid biopsy, to get answers for our patients in a very quick manner. Today, liquid biopsies are becoming pretty routine. And now from clinical grade vendors, we can get blood-based tumor mutational burden, and microsatellite status is now available. So I'm going to pause there, and hopefully some of these examples with rare tumors and with pancreatic cancer illustrate what the power of precision oncology is in determining the right therapy for the right patient each time. Remembering that every patient with metastatic disease, each of these tumors are different. We compare them to snowflakes. I live in California, but I grew up in Canada. Snowflakes are individually rare. I would shut it down now. Snowflakes are individually rare, and snowflakes are individually different. They're very complicated, but the crystal structure from each one of them is different. And the crystal structure from each one of them is very complex. And that's what we believe about the genomic sequencing of tumors. Each tumor is complicated. Each tumor is different. And we need to use that genomic information to match patients with the right drugs. I've tried to illustrate that with some patients. And thank you very much, and happy to entertain any questions.
Thank you so much, Dr. Kurzrock. It was very enlightening and being able to have this opportunity to hear from you. In order to be respectful of everyone's time, we have over 230 different attendees right now across our platform being able to listen to this talk, and we're selecting some of the questions right now. One of the questions comes from us, and it says, "Hello, doctor. As most of the tumors have a p53 gene mutation, wouldn't it be a waste of time to treat with a platinum-based drug? Still, it's been used as first-line therapy for some tumors like ovarian cancer, but is there any significance of using those drugs? Will the genome sequence become mandatory before starting the therapy? As immune therapy is more reliable, wouldn't it be just started as a first line?"
So I think there's a few questions in that question.
Sure.
So I'm going to try but they're very good questions.
Of course.
So the first thing is that cisplatin works for some patients. And I think we can roll back why it works for some patients. Some patients have DNA damage repair defects. So the difference with what we're doing in precision oncology is we're trying to figure out the defects in individual tumors and pick the tumors for which cisplatin will be effective. The second part of that question is p53. p53 is a gene that is mutated in about 40% of cancers. And it does a lot of different things. And it is very difficult to target p53 because of all the different things it does. But I would be careful in saying it's undruggable. It was just a little while ago we said that KRAS was undruggable, and now we can drug it. And I believe that will happen with p53. But what do we do in the meantime? One thing we found is that one of the things that p53 does that is very important is it increases angiogenesis, increases VEGF and VEGFR levels. And so we target p53 with VEGFR inhibitors such as bevacizumab or small molecule inhibitors. We've published pretty extensively on this, that this is actually effective. It's not totally effective. We wouldn't expect it to be totally effective because p53 does so many different things, but it does increase PFS if you use a VEGFR inhibitor for p53. And that has now been shown not just by our group, but a group from Europe in sarcomas, and also from a cooperative group headed by Sloan Kettering in gynecologic tumors as well. So one of the ways to target p53 is with VEGF-VEGFR inhibitors, but admittedly it's not perfect because p53 does so many other things, but it's what we include. And then the third part of that question, the way I understood it was, why not just give everybody immunotherapy? Because in some patients it works great. And, I think that there is a desire to almost give everybody immunotherapy. And I would be cautious with that. And the reason for that is I try to show the hyperprogression. There's a subset of patients, first of all, that have pretty devastating side effects from immunotherapy. And then there's an additional subset of patients whose disease accelerates on immunotherapy in a way I never saw with chemotherapy or targeted therapy. So I think immunotherapy, as I said, is some of the best drugs we've ever discovered, but they're not without side effects and downsides. And therefore, I would not indiscriminately give everybody immunotherapy. I would try to pick the patients that are most likely to benefit from that immunotherapy.
So now that you've mentioned the downside, or so to speak, but just given the future landscape of anti-cancer therapies, what role then do you envision for chemo and radiation therapy moving forward?
Yeah, so that's a really good question. I'm not a radiation therapist, but what I'm going to say about chemotherapy, I think, applies to radiation as well. So just like targeted and immunotherapy have gotten better, radiation has gotten much better. The ability to target specific areas and eliminate them without damage to the surrounding tissue, I think is very powerful. And then for chemotherapy, every chemotherapy is actually a targeted therapy. They each have a target. The reason we haven't thought of them as a targeted therapy is we really had no tools to assess the target. But we do have tools now. In fact, we have a lot of tools that aren't being used. I think one of the best examples of chemotherapy is the platinums that was raised before. Platinums are just like PARP inhibitors. I call them a poor man's PARP inhibitor. Patients that have BRCA or other DNA damage response gene defects, they will respond to PARP inhibitors, but they will respond to platinums probably just as well as they respond to PARP inhibitors. And I think that can be extrapolated for many other chemotherapies. We know chemotherapy works. We just have never made the effort to look at biomarkers for chemotherapy. We didn't have those tools. And I think we need to change that. We need to be looking at what are the markers for chemotherapy.
Now, our very own Dr. Gregory Nicholas has a question, and he said that the patient who is cured, would you indicate surgery to remove the small-sized tumor, or when you say cured, do they not need surgery at all?
Well, this particular patient that had liver, lung, probably both of them are cured. And I say that hesitantly, but after 6.5 years, I don't know what else to call it. So the patient with the liver, lung, and brain metastases, when you look at a scan, there still looks like there's something there. I think it's residual fibrosis. We stopped therapy already on him about 3 years ago, and it hasn't come back. So I'm not especially anxious to go in there and do anything, but you do raise a good question. Should these lesions be biopsied to determine, are they just fibrotic? If there is residual disease there, it might be a good idea to just take it out. But my suspicion is that after 6.5 years, any changes that we're seeing are probably fibrotic or scarring changes.
So then this question, we have a podcast, Medicine Beyond the Science. So we also like to think of the qualitative aspects of medicine as well. And you said something very profound at the advent of your talk that I heard. And I just thought it was fascinating that one could not win the race unless they first enter it. And we have a lot of attendees here today who are listening and partaking in this, who are medical students trying to get into research. We make no distinction in the fact that many people, it's overwhelming to be in research, whether it be a graduate student or medical school. What advice would you have for anyone who kind of is facing this uphill, so to speak? And although we all look very successful on the outside, there's always that challenge. And how does one stay motivated, or what advice would you have for them as they move forward in their research capabilities?
Well, that's a very good question. I think that what you're doing here with the pioneers and with IJCR is really wonderful. I'll give you my own experience, and you can, whether it applies or not. I think you have to love what you do, and you have to do what you believe in. And when I was a young faculty, I did my fellowship at MD Anderson, and I wanted to do research. And the advice I got from everybody, because I do lab research as well as clinical, the advice I got from everybody was you can't be in the clinic. It's going to kill your career. Because it's, you need to be in the lab, you need to concentrate on that. And I thought about it, and I love seeing patients. And I just could not walk away from the clinic. And I said, if it kills my career, it kills my career. But I want to see patients. That doesn't mean I want to see patients 5 days a week. It means that I wanted that combination of the laboratory and the clinic. But the conventional wisdom at that time was you shouldn't be in the clinic if you wanted to build a career. So I had to do what was important to me in my heart. And truthfully, I think that's everything to do with my success, because now we can translate things in the clinic, and everything that I look at in the lab or now by computer algorithms, we look at in the clinic, and that's what means something to me. So I think maybe the message is listen to your mentors, but if they tell you not to follow your heart, follow your heart. That's at least what I learned.
Thank you so much, Dr. Kurzrock, for that very honest and open discussion. I just want to thank everybody here who was attending today, for all of you, for your questions, and for just being able to have this discussion and really learn something today. I think it's a fantastic way to spend a weekend, so to speak. With that being said, I just want to encourage everybody to follow IJCR, the International Journal of Clinical Research, on all of our social media platforms, and to reach out to us. We're always looking to be able to discuss medicine and to be able to have that engagement, especially for those who are very interested in research and publication as well. So thank you all, and you all have a great weekend. Take care.
Thank you, and good luck. Appreciate it.
Thank you so much, Doctor.